but in the last 10 years, people have asked, well, you know, maybe there are some alternatives to the mechanical valve that's at the bottom of that plastic tube. The standard being the mechanical, but other options existed to replace the aortic root. You could actually use a homograft, which is it's a human aorta. It's usually a tissue that's been donated by an organ donor, somebody in a car accident, a young person. And these can actually be frozen and sterilized and kept in a tissue bank for decades. They'll actually store for decades. And we actually have a supply of them at the hospital for situations where these are attractive. You don't have to do a tissue match. You don't even have to do a blood group matching on them. You just have to get the size right. And as I say, we have the whole range of sizes. Now this is pretty attractive because you don't need any medicine at all for this. But what the problem is that they wear out. The body actually does reject them. And yes, you could take anti-rejection medicines, but those medicines have so many side effects, it's really not an attractive option long term. But they don't require any blood thinners. That's the attraction. And occasionally we'll still use this, but we're not usually happy about it because we know they're not going to last a long time. Now, how long is a long time? It depends on the age of the patient, and the younger the patient, the more quickly they wear out. And that's the shame, because you wish it were the other way around. So a 5-year-old who gets a homograft might only get 5 years out of it, maybe 7 or 8. Oddly enough, if you're 70 years old and you get one of these, it can last 20 years. It's not fair, but that's the way it is. Now, you can also take other types of animal valves, like a pig valve or a cow valve. Have you all heard about cow valves, bovine pericardial? Have you ever heard that? By the way, they're not actually cow valves. They're man-made valves that use cow tissue, and it's just constructed that way. Now, because it's tissue, you don't have to worry about the clotting, and the advantage of these, whether it's pig or cow, is that you don't have to take the blood thinner. But just like these human valves, they wear out. They're not living tissues, they just wear out. So, again, you may not get more than 5 or 10 years in a young person. And that's why we're not crazy about using them in very, very young people, because that's just not a long time. How many of you have ever heard about the Ross procedure? Good, I don't even have to talk about this then, because I only put this slide up there to tell you that it has absolutely no role here at all. But everybody asks me, well, why can't my child have a Ross procedure? Because they read about it on the internet. The internet, by the way, I mean, it's a great thing. I love the internet. And there's no question the internet has been, in the total balance, a wonderful thing in keeping people informed, letting them know what their options are. But it often stimulates a lot of questions that it's good that we have to address them. It's good that we have to talk. But sometimes it really complicates things. And my favorite quote about getting medical information off the internet is that it's like drinking from a fire hose. You're just inundated by all this information, and somehow at the end of the day, you're still thirsty. And what you're thirsty for is wisdom. The internet is great on information, but not always great on wisdom, because you don't know who's posting the information on. But listen, I don't mean to disparage the internet. It's a wonderful thing. I think it's been the best thing that has ever happened for patient advocacy in this country. And in the balance, it's wonderful. But people do come and they ask me, why not a Ross procedure? Well, a Ross procedure, by the way, just to go back to this. Oops. This is a fancy operation. By the way, this is the operation that Arnold Schwarzenegger had. People may have known that he had a heart operation about 10 years ago. He had a problem with his aortic valve. He didn't have an aneurysm, he had a problem with the valve. And one of the operations you can do for an aortic valve problem is move one of the other heart valves, the pulmonary valve, over and replace the aortic valve with the patient's own pulmonary valve. It's kind of like a shell game a bit. And then what you take that homograft or human valve and put it where the pulmonary valve was. Now, it's actually a very good operation for people, young people, who have aortic valve problems. But it's not a good operation for people who have aneurysms. And the problem is that the pulmonary valve here, it comes in its own little wall of tissue, but that wall has the same weakness as the aorta. So if you do a Ross procedure in a patient with Loeys-Dietz syndrome, he or she's just going to develop a new aneurysm, probably a lot quicker. It's a good operation for people with valve disease, but not aneurysms. So it really doesn't have a role in Loeys-Dietz syndrome. So that's all I have to say about that one. Now, the operation that everybody is interested in and is excited about is something called a valve-sparing aortic root replacement, and we just abbreviate it usually VSRRs. In this operation, we just replace the aorta with a plastic tube, but we keep the valve. The interesting thing is that in Marfan syndrome and Loeys-Dietz syndrome, the valve is usually okay. The valve is working well. It's sitting inside a big aorta. And the aorta is the problem, but the valve is not the problem. And it's a shame to replace the valve if there's nothing really wrong with it. So this operation, which was developed about 15 years ago, replaces the aorta, but it leaves the valve. It's a little trickier to do because you have to sew the valve inside it just right. And in the end, it looks like this. You're staring down in there, and there are the three flaps of a normal valve. But the beauty of it is that the patient doesn't need any special medicines. It's his own valve. He's not going to reject it. They're going to have clot on it. Yes?
Sorry to interrupt you, but I was curious when you said the VSRR, saving the valve, can it also be done if the patient has a BAV?
It can be, if the BAV is working well. And most of the time it is in Loeys-Dietz syndrome and Marfan syndrome. If the valve is a problem, if it's leaking a lot or if it's narrow, then you have to think about replacing the valve. But most of the time, it's working fine. And we do have some experience doing this operation with, and BAV is bicuspid aortic valve. I don't know how many of you know about that, but the aortic valve normally has three flaps that open and close. Bicuspid aortic valve, there are only two flaps. And if you have only two flaps, you're a little more likely to have a problem with the valve, either leaking or becoming narrowed. Bicuspid aortic valves happen about 2% of the population at large, and about 2% of Marfan syndrome patients, and I think it's higher in Loeys-Dietz syndrome. We don't know exactly yet because the numbers are still small, but I think this is going to be a situation that we see more commonly, so it's a great question that you asked. Now, as you start to read about root replacement and saving the valve, you're going to hear two other words that I want to explain to you. This thing called a remodeling operation versus a reimplantation operation. These were terms that were used to describe two major forms of this operation, and the terms came from Dr. Tyrone David in Canada, who really has been the major pioneer, I think, for this kind of surgery. I'm not going to go into detail, but I'm just going to tell you the big difference in this is that although both of them use a plastic tube to replace the aorta, there's a difference in how that tube either sits on top of the valve or around it. In the remodeling operation, that tube is scalloped at the bottom, so it has sort of three little tongues that are sewn to the edge of the valve, but it really sits on top of the valve. And the problem with that is that in patients with connective tissue problems, those three tongues of the graft can start to splay out, and they stretch, and then the valve starts to leak. And we learned this the hard way in the first 10 years of experience doing this operation in people with Loeys-Dietz syndrome and Marfan syndrome. Not all of them. In fact, most of them still did okay with this surgery, but too many of them developed leaks years later and then had to have surgery again. The reimplantation operation has a little different approach to it. It takes the plastic tube, whether it's a straight one or one that has a little bulge at the bottom, which is called a Valsalva graft. That's the one that we like to use. But it slides that tube down around the whole valve, and it actually sits down below the level of the valve. So the entire valve is inside the graft, and what that means is that it can't stretch. It's contained inside that graft. The grafts do not stretch, by the way. They stretch by a millimeter or two, but not much. And it's a much better operation for people with connective tissue disorders. So if you're going to have a valve-sparing operation, it must be the reimplantation operation. When I say you, I mean people who with connective tissue disorders. And we actually would include bicuspid aortic valve as having a connective tissue disorder. Bicuspid aortic valve without Loeys-Dietz syndrome. So those are the distinctions there. And let me just share with you our updated experience with aortic root replacement. This is all valve sparing in Loeys-Dietz syndrome. This is 8 years of experience at our institution. 31 patients. You know, this is not a common disease. That's why, that's why we're sitting in a relatively small room here compared to a convention center. 31 patients, and this is the biggest experience in the world. The mean age was 15, and our youngest was less than 1. The size of the aorta at the sinuses on average was 3.9, but that included, some who were closer to 3 and some that were more than 4. And only about 6% of them had more than moderate leakage of the valve. And this just shows what I said before, that most of the time the valve is working okay. So it makes sense to save it and then avoid all the problems associated with artificial valves. 30 of these had an operation called the reimplantation type. That's the one that stabilizes the valve. Now, we did one called a Florida sleeve. Have any of you heard about that operation? This is one Florida sleeve. So I'll show you a picture of that in a second. But it's a different way to do an operation like this that is a little simpler, but we're not quite sure that it's a better one in the long run. Our follow-up is a little over 3 years. Everybody survived the surgery. This is an important point, at least in our hands. And I'm not saying it's zero risk of death. It's not. It's probably about 1%. But that's low. And for most of the people we're operating on, that risk is a lot lower than the risk of living within aorta. That's that size. We're happy that in follow-up, nobody has developed significant leakage. And that's an important point too, so that not only does the operation work in the short run, but at least at medium term, out to a few years, the valves are still working well. And we've had 3 reoperations, one because of a small aneurysm that developed where the coronary artery was implanted, and then 2 because of pseudoaneurysms which are basically contained leaks at the suture line. Now, people don't bleed from that because it's contained by scar tissue, but it's not a stable situation. So if we see these things called pseudoaneurysms, we fix them because we do think they get bigger and they can actually rupture late. And this is a higher incidence than we see with other types of aneurysm surgery, and definitely higher than even in Marfan syndrome, which tells us what you know already, that this is a more severe connective tissue disorder. The tissues are weaker than in Marfan syndrome. This is just a picture of that Florida sleeve operation. In that operation, the surgeons don't remove that sinuses. They just put a Dacron graft around it. They wrap it. And it makes it a little easier because you don't have to detach and then reattach the coronary arteries. But from our perspective, the problem for that is that you have to make room for those coronary arteries to leave, because you still got to get blood to the heart muscle. And if you make that little keyhole there too big, they'll develop an aneurysm, which is what one of our patients had. But if you make it too small, you can pinch the artery, and then you don't get enough blood through the artery to meet the needs of the heart muscle. So getting this just right is sometimes a challenge. And there have been some late problems. I mentioned the pseudoaneurysm. This is a CT scan showing, this is actually the graft here, and a small leak that developed right there at the base of the graft where the tissue was extremely weak. And that patient was reoperated on in Michigan recently and just had that little thing fixed and now is doing well. And this is also another problem that can develop the way the aorta, beyond where we operated on, can still develop worsening tortuosity. We're just starting now to realize that these are problems that are not going to be fixed just by root replacement, and we're going to have to figure out ways to either prevent or address those later on.